So I wanted to start with, as we tend to do, closer to home. Um, we had a couple of days of um, deaths sort of under 600, and then we had a spike the day before yesterday, and then back in the 700s today, it seems. Um, and so it seems that the UK is definitely peaks, but at a plateau. And I'd love you to just reflect on what you think that means vis-a-vis other countries, and what you're crystal balling what the next couple of weeks are likely to look like as a result.
Sure, Paul, thanks. And of course, we're also eager for this to get better, that we, obsessively follow the numbers every day. And it's a good reminder that there's always going to be noise, and we have to look for the signal. And that signal is really going to be about trends. Typically, what we found also is that, especially on the weekends, reporting tends to be lower. And then some of those counts come on Monday and Tuesday. So you'll see a little bit of a dip and then a little bit of a spike. But if you look at it across, it kind of all evens out. What we're seeing is the same thing we've seen in the other hard-hit countries like Italy and Spain that are a few weeks ahead of us, in that when you reach a peak, it's not that all of a sudden there's a steep drop-off back to happy times, that really is kind of a plateau, and it can be a very slow decline from there. And that's kind of where we're at. We're a little bit lower than our sort of peak was about 750 deaths per day. The recent average is a little bit lower than that, but we should expect that we're going to potentially be seeing numbers kind of like this, and it's going to be a slow decline over weeks, as opposed to a steep drop off after that, unfortunately.
And so so a slight decline. We had a session yesterday with a colleague, a conduit member who also is a frontline NHS worker, who is saying that the number of people in hospitals are coming down, not going up. About 5 or 6,000 people emptied out of London hospitals over the last week, and it seems as though, and I'd love to hear your view on this, is that if the worst is over I mean, more deaths are still terrible, so I always qualify my use of language, but if the worst is over in terms of mortality rates, will we look back and say that the NHS broadly coped, that we didn't have scenes of terrible triage in corridors, that there were still very, very scary and hard moments, but the system braced itself and then and coped with the surge?
I think so. First, that other point is really important, that what we're kind of seeing, remember, death is going to be a real lagging indicator. And a lot of people who ultimately succumb to the disease spend several weeks on a ventilator with heroic efforts to try to keep them alive. So the fact that we're seeing and hearing these reports of a real drop in the number of new patients coming in and being hospitalized is definitely a hopeful sign that we're headed in the right direction. And that, again, lagging indicator deaths will decline a little bit further on. I would say that if things continue to slowly and steadily improve from here, then the answer would be, generally yes, that the NHS was able to cope and to respond really well, despite tremendous, tremendous pressure, and at least avoid the kinds of breakdowns, if you will, that we saw coming out of countries like Italy, where you had these terrible decisions about which patients should get the ventilator and which ones shouldn't get the ventilator, right? We're able to avoid those kinds of things. So largely, I think we should really applaud the heroic work that's being done in the NHS, and all the work to kind of build emergency capacity to do so. There's going to be more to come, I think, to fully understand the impact of all of this. We focus a lot on the number of people losing their lives to this disease. The other thing that is harder to gauge in the short term is what's the impact on the health of the population from everything else. And one part of that is how well has the health system been able to cope for people with every other kind of condition. So we've seen the number of new cancer diagnoses go way down because people aren't able to be screened or tested for symptoms, et cetera, et cetera. So there's going to be some fallout from this for some time to come, and increased amounts of morbidity and mortality that's not directly related to COVID. And that's unfortunately true just about everywhere that's been hard hit. But overall, yes, and bravo to the NHS. They're doing amazing work.
So let's turn to the PPE scandal. I mean, my word, but I mean, to be told, look, we've run out of it. You just going to have to go take a plastic apron and off you go. But also, it seems as each day goes past, there is another revelation about an opportunity missed to acquire, to procure, to adequately prepare. The fact that we are anxiously watching a plane from Turkish Airlines landing in order to rush PPE into our hospitals tells you how precarious the situation is. Your perspective on this?
Yeah, I think I used the word scandal in talking about this a few days ago on a news program, and I received quite a bit of trolling afterwards. And I only mentioned this because my favorite of all the trolls went by the name Vladimir Poutine, as in the Canadian delicacy, chips plus gravy plus cheese. And I thought, well, you're attacking the wrong country, but that's okay. Yeah, it's obviously hard to watch. And then, for me as a health worker with lots of friends and colleagues who are on the front lines, it's unconscionable to think that they're being asked to, not only work as hard as they're working, but to put themselves and their families at risk because we can't give them appropriate PPE. And the fact that we have now resorted to measures that, to be honest, I had the privilege of working for the Rwandan Ministry of Health in some capacity for several years. If I had ever proposed guidelines that said, here's how you can reuse PPE in an epidemic setting, I think I would have been fired. I don't think Rwanda would have tolerated some of the things that health workers here are being asked to tolerate. And that is what it is. And it's just a jarring reminder of kind of how far outside of the norm we are right now. And, we've all seen the reports that some of this goes back to poor planning in recent years, that there were studies that showed that a pandemic would overwhelm the NHS and that our stocks of PPE were inadequate, but no efforts were really made to build up the strategic emergency stockpile. In fact, a lot of it was expired, and then all the other reports of missed opportunities to get it. So it's hard to see. And I hope it gets better. And the one thing I guess I have to say is, I've been critical of the government response at times. This is really hard, and we're in a data-free zone, and there are global shortages. I just wish that there would be a sign that we're learning from the mistakes when we make mistakes, so that we know we're going to be better moving forward, because we still have a long ways to go. So
speaking of mistakes and moving forward, I think it inevitably takes us to the state of testing. It's still, the UK on a per capita basis is, I would say, outside the norm or outside its comparable control group of other countries similarly situated. And that may be one thing to say, well, look, we just muddle through. But I want to understand from you what the consequences will be as we count down from the lockdown and start going back to normality. Will there be a corresponding ramp up in testing ability to sort of match us emerging, or are we going to inherit this sort of underfunded, under-resourced testing environment, and that may then jeopardize, put us back into second outbreak mode? What's the correlation between the successful emerging from lockdown and testing?
In my view, and I think in the views of most in the public health community, adequate testing capacity, which means a lot more than we have right now, is absolutely critical, right? As we relax social distancing measures, whether that's a little bit or a lot, and we can talk about how you do that and how much we need to learn about it, we know that you're going to be putting more people into proximity, and there's going to be more opportunity for this virus to begin to spread again. What you need then to be able to do, we're kind of in this mitigation phase where things kind of got a little bit out of control, and then we had to take these extraordinary lockdown measures to then flatten the curve and save lives, right, and buy us time. We need to go from mitigation back to a containment stage, which is kind of what we missed or lost earlier on. And containment is all about being able to identify cases early, being able to trace all of those cases' contacts, and then isolating everybody who needs to, right? So that means that everybody who has symptoms, at the very least, needs to get a test. If you look at China, in some parts of China right now, as they begin to open up, you have to get tested if you want to go to work every 7 days and have a certificate that lasts 7 days to show that you're safe, and there's temperature checks and lots of other things happening. So you could sort of extrapolate to the population here. We would need to be probably well over 100,000 tests a day, the stated goal. Right now, we're still in the 10 to 12,000 tests a day range. The government's sort of 5 criteria for ending lockdowns. The 5th one is adequate testing, but it's really vague about what that means. And so, I don't know. We're nowhere near where I think we need to be able to safely start to move towards a bit of normality. And I still don't see how we're going to get there. And it just makes me wonder. I get that there are challenges. I get that there are global shortages of swabs, global shortages of reagents, but we also have an extraordinary network of private and university laboratories in this country, which are not being tapped into. And I feel like if we really gave it all our effort, we could be doing better than we are now, but it's my view from the outside.
So I want to ask you a sort of intersection between kind of public health and sociology, which is at some point the lockdown will end. And at that point, right now, in some ways, that what the lockdown does is save us from making choices about what we do and what sort of risks we're prepared as individuals to take, because we've just been told, stay in place, stay at home, can't play football in the park, don't go to work, blah, blah, blah. That will end. And that will end probably in the next 30 days. I mean, could be 6 weeks, but it's not that far away. Mm-hmm. And then we are going to be having to make more individual decisions about what we are going to do, which corresponds to our own psychology, our own sense of risk, and most fundamentally, our confidence that both the public health system won't be overwhelmed and that there's sort of some collective effort to make us feel safe. Mm-hmm. And if there isn't a lot of testing, I think that erodes that in my mind. But I guess the question becomes, do you think that there will be, for at least the next 6 months or maybe longer, a quite demonstrable change in all of our behavior, parks, restaurants, nightlife, sporting events, because everybody's going to have to make up their own rules about what they're prepared to do?
I mean, I hope it's not a free for all, and I hope that there's going to be some good guidance about this. But the answer is yes, for the next 6 months. Will there be a complicated, delicate balancing act that doesn't feel normal? Absolutely. We're not going to be at normal 6 months from now, in my view. And so we'll see some things that are going to be opened back up, but there's probably still going to be social distancing measures, right? So maybe more shops will be open, but there'll still have to be restrictions on how many people are in those shops at any given time. More workplaces are going to be open, but there's still going to have to be flexibility about where people work from to try to reduce proximity within offices. When schools get back open, this is a really, really tough one to figure out how you're going to be able to do social distancing in schools and keep kids 2 meters apart in tiny unventilated classrooms. And that might mean having kids go to school for half days or 1 week on, 1 week off. As health systems open back up and start doing elective surgeries, they may need to move to evening and weekend hours so they can keep waiting rooms from getting congested. I don't know how restaurants are going to do it. I don't know how pubs are going to do it. I don't see a major gathering that's going to bring thousands of people together happening in this calendar year, personally. So there's a lot, and this is pretty uncharted territory, right? No one's done this. We have historical experience from Spanish flu and a couple of other, major epidemics in the last kind of 100 years. And now we're gaining all these little bits of experience from Asian countries first, and now some other countries in Europe, which are starting to experiment with opening back up. honestly, nobody exactly knows exactly how best to do this. And I think there's going to be some trial and error. And that's why really good intelligence from lots of testing is going to be important, and really good and transparent leadership that's going to be able to kind of hold people together, give all of us the confidence that someone's got our back, is going to be really important. Because you can give whatever directive you want, but if I don't feel safe sending my kids back to school, I'm not going to. The economy is not going to reopen if people are not participating in the economy because they don't feel safe. And that's why the public health and the social and the economic really all go hand in hand.
So let's come back to my favorite silver bullet, because, you know, it's the only thing that keeps me sort of optimistic. I'm kidding. I am very optimistic, but just you're in the heart of Oxford. There are some quite exciting vaccine initiatives and trials emerging not too far from where you're sitting today. Tell us a little bit about them and the general speed at which this is going. And two questions is, how promising are they? When will we know that we actually have something? And when will we start seeing, with what degree of likelihood will we start seeing a vaccine issued at scale?
Yeah, so the first vaccine to enter human trials is moving forward now, and it sounds like the first subjects will start receiving jabs in a matter of days. This is the trial that I enrolled in 2 weeks ago, and they said we need about 2 weeks to do some kind of rapid animal safety testing in apes, I believe, before we can give it to humans. But it looks like they're on schedule to do that. So that's terrific. That's a vaccine, again, that's based on sort of a technology and the use of an inactive virus that's already been used in for some other pathogens, and they just added the so-called spike protein that gives the coronavirus its crown-like spikes, which, because that's how it enters cells, we think is the most salient target for a vaccine and for an antibody response. So people are going to start probably actually getting jabs within days. They're enrolling 500 people. I imagine it'll take a couple of months for all of those folks to then get enrolled and get their vaccine. Of course, this is different than a medication trial, where if you're giving me an antiviral medication or a blood pressure medication, you can try to measure my viral load or my blood pressure today and the next day and the next day and the next day. With a vaccine, you're trying to measure the absence of infection, right? So they may be able to do some things like try to, and they will do this for a small number of subjects, look for an antibody response in the blood and things like that, which could give you a predictor that it might be working. But ultimately, what you have to do is give it a period of time when you would expect to see some difference between those who got a vaccine and those who got a placebo, with more people with a placebo actually getting infected over time. And so with 500 people and waiting for that to happen, realistically, that's still going to take months before you're going to see some evidence that it's working. So this is not the sort of thing where a few weeks down the road, we're going to see amazing results, or even anecdotally really promising results, as you sometimes hear with some of the drugs that are out there. So this is exciting. It's a candidate that has, I think, promise. It's great that it's happening here. And there was an announcement by Matt Hancock a couple of days ago about a big sort of government-sponsored vaccine initiative to do a lot more like this and really try to keep the country on the vanguard. And I think that's very promising and hopeful. And they're doing that in cooperation with CEPI and other global networks to do this. We're still looking at uncertainty, meaning we don't know if any of these will work. The diversity of them gives us more confidence, but it's never been done for a coronavirus before. We don't know much about how long it would last. And so we still have to be humble and expect that probably within 2020, widespread availability of a vaccine is extremely unlikely. We can be optimistic for 2021 being able to see something. And there are at least some efforts underway to build up the manufacturing capacity so that a successful vaccine could be manufactured at scale fairly quickly. But you could still imagine all kinds of problems where, countries are trying to protect vaccines for themselves and not give it to others, where the poorest communities in the poorest countries are going to be less likely to have access. And that's why some efforts underway that are being coordinated by World Health Organization to try to have a cooperative response that we need to all work together as a planet to figure out how to rationally and ethically distribute a limited resource to the places it's going to do the most good is going to be really important. You know what Trump would say if the first successful vaccine was developed in the US. Nobody outside of the US would get that vaccine until everybody in the US got it, right? And those are the kinds of things we need to avoid.
I want to ask you about Singapore. We were chatting about it earlier, but obviously a place that was held as the kind of gold standard of how you deal with testing, contact tracing, isolation, high quality care. Now we've seen the reimposition, of a lockdown and an extension of a lockdown and some very significant spikes, particularly amongst guest workers. Tell us a little bit about what that tells us about efforts to emerge intact from the epidemic.
Yeah, as you say, Paul, Singapore was totally on this early on, and they had an extraordinary response. They did all the things you said with surgical precision. And what we're talking about now is sometimes being called a second spike. They almost didn't have a first spike because they responded so well early on. But what we're seeing now is thousands of new cases in Singapore, which is a very small city-state, and that's really concerning. A new lockdown being sort of reimposed. We're seeing something like 2/3 of those new infections be amongst migrant worker communities, mostly from Bangladesh and India, who are living mostly in very crowded dormitory-like facilities, and are kind of they're an underclass in Singapore, right? They don't have a lot of the rights of citizens, and they're kind of this, this very large silent community of folks who kind of make things work in Singapore. And so I think it teaches us two really important lessons, at least at this stage. Number one, easing lockdowns is going to be really hard. We're still learning, but we know how quickly this virus spreads and replicates, and any efforts to kind of ease things is just going to be difficult. It's going to be a tenuous balance. A lot of the places now that are talking about it may not quite be ready. So I think it's going to be harder to open up than maybe even I sometimes hoped a couple of weeks ago. So that's one, humility. It's going to be hard. Two, we ignore our most vulnerable communities at our peril. And many societies have been for a long time, obviously. And this is exposing those kinds of inequities in ways that actually make everybody less safe, right? So here in Singapore, it's migrant workers. Here, of course, we've seen the virus spread like wildfire through our care homes, affecting our elderly. We've seen outbreaks in prisons. We've seen outbreaks in urban poor communities of color in a lot of cities and a lot of places. And, unless we're able to have a kind of preferential response that addresses the risk in those communities, the entire populations are going to be at risk. So protecting our most vulnerable is not just, morally sound, but it's epidemiologically smart. And I think that's an important lesson.
Yeah, we've spoken many times about the mirrors and the magnifying glasses of Corona. And I think when we look back on it and look through the numbers and see where the disproportionate deaths will be a very good map into where inequality and maldistributions of privilege and power lie, and probably a good place to start to kind of build back better, a more decent society. I wanted to, speaking of which, do a little quick detour into the US. Some of the kind of ginned up protest movements in certain states to try and counteract the liberty depriving lockdowns of democratic governors largely. I mean, we know where that comes from, but just how serious is this, and how does a federal country like the United States, given its very divided governance, get on top of the pandemic?
Maybe before going into that, I just saw a Q&A pop up on what we just talked about from Sean.
Yeah, please, go for it.
About any updates on studies looking at how the virus is affecting BAME people more. The answer is not to my knowledge. We're seeing a lot more pressure for more places to actually record data on race and ethnicity in their reporting. And I think there are a lot of studies ongoing now. I've not seen any that have actually come to publication, but I'll keep an eye on that and we can try to follow up on it next week. with regard to the US, so what we're seeing right now is that in some ways it's surprising it took this long, but the virus is being politicized, and the pandemic is essentially falling along the fault lines of polarization that we've seen in the US be amplified, particularly so much over the last few years. And it's totally political, right? So we've seen protests, mostly pretty small, but folks out with the kind of "Don't Tread on Me" banners that were emblematic of the Tea Party a decade ago, that have been egged on by conservative media and egged on by the president, that are happening, pushing for ending lockdowns and opening society back up, and sometimes muddled with gun rights and anti-abortion and other kinds of things happening. What's telling, I think, is that most of these protests are happening in swing states with Democratic governors, right? And so I think what it looks like is this is a political strategy to try to shore up the base by politicizing this crisis. And the problem is it's going to potentially put everybody at risk. And so we've already started to see some new cases in Wisconsin that were related to the election that was held there a few weeks ago that have been actually traced back there's one cluster so far in Milwaukee that was traced back to one polling station of both a poll worker and some voters. And we'll see more of that. The kinds of things, like, we've learned that gatherings have been really powerful drivers of this epidemic everywhere, right? And we've talked about this in the past. Mardi Gras, a church in Korea, the Cheltenham Festival here in the UK, events where you bring a whole bunch of people together for a period of time, lots of other kinds of churches, funerals, et cetera, et cetera. That's what these protests are. So we're basically organizing super spreader events that are going to risk continuing to kind of spread this, and paradoxically are going to make it harder to ever end the lockdowns in these very places. And I guess they're just betting that maybe the Democratic governors will get the blame somehow, and that will that will end up to their political advantage come November. It's kind of insane, and it's really sad to see it happening. In some ways, I guess not surprising given how polarized we are. It's going to be really interesting to see what happens, if that strategy is going to work and play out, or if we're actually going to see things get worse in some of those places in ways that will smack some sense into everyone. I don't know.
I want to do a final question, which sort of tees off this, which is, do we have any clear data in the UK or other places about our best estimates of the number of people who have been infected, and our base levels of, therefore, what we should model as sort of societal immunity as we emerge? And connected to that, and vis-a-vis the Singapore conversation we just had, is it going to be very, very, very difficult in societies where you do have significant pockets of inequality, where you're unable to impose, either for reasons of cultural trust or just government dysfunction, very strict regulated norms of behavior? Is it almost inevitable that we'll see second outbreaks, because just the immunity numbers that I've been looking at seem to me quite low? It's obviously hard to measure a negative, but I'd love you to dig into that question.
Yeah, so I mean, if you take the 134,000 cases we've had in the UK so far, and say that it's 10 times that in real life, 1.3 million, that's still a fraction of the 66 million, right? We're talking of a handful percent. So early evidence coming. The way we're going to figure this out is from sero surveys. So that's testing of antibodies, the thing the body makes after having been infected, and in doing that in a methodical way where you randomly test the population and then you use that to infer. So you test 10,000 randomly selected people or households in a population, and then you use that to infer how many have evidence of previous infection, right? We don't know if that means immunity, but we suspect it does. Germany have the best data so far. They have a nationwide survey or multiple nested surveys ongoing right now. First thing I saw published that came from some of the initial hotspots came in at 14% of the population having had evidence of infection. But those are in the places where there was the most concentrated spread. You would anticipate that nationwide numbers will come in a little bit less than that. A couple of, I think Santa Clara County and LA have started reporting some results of surveys there, but they were not randomized. And so they estimated, I think, somewhere between 3 and 6%. But it was a weird kind of thing where people could just show up and get tested if they want to. That's not going to give you an accurate sort of picture. Some countries in Asia, Germany, are doing these things. France is planning a sero survey. The UK initially was betting big on antibody testing, but unfortunately, the tests that are done in laboratories are decent, and a lot of the rapid home antibody tests are proving actually to be really, really inaccurate. You may have heard that millions were sort of purchased by the government, and they had to send them back because they didn't work. So I don't know if there are plans to do that now. Again, we're probably looking at somewhere between 5 and 10% of the population in a lot of the hard-hit European countries actually having evidence of prior immunity. That's not enough for any kind of herd immunity, right? 60% or more is what we're estimating for that. But it's helpful intelligence for us to start to think about how we can be sophisticated in planning what society is going to look like over the next, kind of months and years to come.
So if the number is that, and then we come out, is the less R1, R0 will if you've got a very low number of people, less than 10% infected, then you've got 90% you can still get it, and it can spread. All the effort that you've invested to crush it can come back, especially because it's so wildly infectious or contagious. But does it matter that you've got it down to beneath 5% and therefore it's difficult to break out, or can you just all your hard work basically goes to naught?
It depends how long any immunity lasts for. So it's not herd immunity this is a gradual thing, right? So the more people who are walking around who have some immunity, the fewer people who are vulnerable to infection, and then the lower the R0. So if you say the R0 is 3, so one infected person infects 3 others, on average, it might be, and I'm kind of making up numbers here, if you get to 60% in the population having antibodies, then that number falls below 1. So maybe it is that if 30% of the population have been infected, that R0 drops to 2 just by virtue of the existing immunity in the population, which would mean we would need to do less other kind of social distancing interventions to get to a safe place. So it's true that the more people, obviously, who have evidence of prior infection and some immunity, the better off we're going to be and the easier it would be to open things up. And of course, you can think about how we could be sophisticated about this and say that people who have immunity can be doing certain jobs or certain roles or go back to work, et cetera. That's fraught, as we've talked about before. So to an extent, there's an advantage that comes from higher levels of infection. And so maybe we'll get lucky and it turns out there have been lots of asymptomatic infections in the UK that will help us over time. But that's the same principle as vaccination, right?
We're going to end, but I do feel as though Kanav, who's lovely, we should just ask, because I'm concerned about places like Brazil, where government has largely ignored the population in the informal communities and the lack of reporting surrounding this. I guess this is slightly more of a political question, but do we have any medical hope for those regions?
I think in general, in a lot of emerging economies and poor and middle income countries, there's still a ton of risk for a lot of obvious reasons. A lot of places in Africa have taken this very seriously and had really robust responses and should be applauded for that. And we hope that it will be enough and we can support them enough to stave this off. Brazil is certainly one of the places that I've been worried about as well for the reasons that you mentioned, because they're not doing the things that we know work. They're almost flouting it. And you're absolutely right that the poorest communities that are living in really close proximity, this is a virus that could tear through communities like that. We don't have any early warning signs because testing is not happening. So it's a tinderbox, and there's definitely a real risk that we could see that we could see a really significant outbreak there in the weeks to come. What we can do about that, short of changing the political leadership, I'm not sure.
Right. Change of political leadership will help with climate as well. It'll probably protect the Amazon as well.
Exactly.
But that's another conversation. Peter, as always, thank you so much. So great to see you. We'll see you again next week. And thank you, everybody, for joining.